So starting with the urology. Now in this urology section, the first that we'll talk about is the testis. Now the first is the anatomy of the testis. There are three layers from outside to inside. There is tunica vaginalis, then tunica albuginea, and then the tunica vasculosum. The site of spermatogenesis is going to be the Sertoli cells inside the seminiferous tubules. Rete testis. Rete testis is the one that transfers the sperms into the epididymis, and epididymis is the one where the maturation of sperms happens and it carries to the vas deferens. Now there are two types of thing, that is the left testicular vein and the right testicular vein. More impact is on the left testicular vein because left testicular vein is drains into the left renal vein at right angles, so there are more chances of varicocele over here. Right testicular vein, it drains directly into the IVC. Then lymphatics, the left side testis, it drains into the para-aortic lymph nodes, while the right side, it drains into the inter-aortocaval lymph nodes. Now the first disease, that is the undescended testis. Undescended testis, for that the testis, they develop in the genital ridge. Now there are certain triggers that help in the descent of the testis. There are three important triggers. The first is the pull of the gubernaculum, then the hormonal factors, but the most important is the differential growth of the abdominal wall. So differential growth of the abdominal wall is the most important. Timeline for the descent of the testis: at around 3 months, the descent of the testis begins. In 6 months, it is present at the level of iliac fossa. At the 7th month, it is present in the inguinal region. Then at the 8th month, it is present at the superficial inguinal ring, and at 9th month, there is a complete descent of the testis. Now, first left testis descent and then the right testis descent, and because of which normally or physiologically also the left testis is located lower as compared to the right testis. Most common site of arrest is going to be at the inguinal region. Then most commonly there is a right and descended testis as compared to left in unilateral. Bilateral and descended testis is what we call as cryptorchidism. What are the changes in undescended testis? So obviously the volume of the testis will decrease. Then it increases the risk of intra-testicular germ cell neoplasm, that is more risk of seminoma happens. Then Sertoli cells, they are going to be affected, and because of which the spermatogenesis won't happen. Leydig cells are not much affected, because of which the secondary sexual characteristics, the muscular characteristics, they will be preserved. Complications, they are given by the pneumonic testis itself, for which the T stands for the trauma, then E stands for the epididymoarthritis, then the S stands for the sterility. Now sterility is a very important thing, because even after performing the surgery, the sterility factor, it may remain. Then the T stands for the torsion, and the I, which is the most common complication, is the indirect inguinal hernia, and then lastly is going to be the S stands for the seminoma. Seminoma is the most common malignancy for which the surgery is to be carried out. If the orchidopexy is carried out before puberty, then the chances of seminoma are twice to thrice of the population, and if it is after puberty, then up to 5 to 6 times the normal population. Management. So timeline of the management is important. Spontaneous descent of the testis sometimes happen up to 6 months, 5 to 6 months of age. Surgery ideally should be carried out about 6 to 12 months of age. Then it is a bilateral undescended testis, that is cryptorchidism. Then in that case, first we give a hormonal injection, that is injection beta HCG levels. So if you give beta HCG, if there is an increase in testosterone, FSH and LH, then that means the testis is present, and we go for laparoscopic exploration. If there is no response, then that means it's a case of anorchia. In unilateral undescended testis, we first only go for laparoscopic exploration. If there is an intra-abdominal testis are seen, then we look for whether it's a necrotic or viable. If it's necrotic, we do orchidectomy. If it is viable, orchidopexy is done. Vessels seen exiting the deep ring, then also orchidopexy is done. If there are blind ending vessels, then that means it's a case of monoarchia, or that remaining testis has underwent torsion. The types of orchidopexy. So the most common type is going to be the Silbar method, where the testicular vessels are cut and anastomosis is done with the branches of internal iliac artery. Then Kittley-Torek method is used. Another method is called as the Fowler-Stephens method. In the Fowler-Stephens method, it's a two-stage method where the high ligation of the testicular vessels is done. Then the testis is mobilized into the inguinal canal, and after a few weeks, it is mobilized into the scrotum. Then some variants, they include ectopic testis. The most common site of ectopic testis is going to be in the superficial inguinal pouch. Another sites can be root of penis, or it can be in the femoral triangle. Management is orchidopexy. Retractile testis is completely physiological in nature. Sometimes the testis can jump into the inguinal canal. Now, the testicular torsion, there are multiple risk factors for testicular torsion, the most common cause being the bell clapper testis. Apart from that, another causes can be the testicular inversion, undescended testis, then the one having a blue dot sign on the Doppler. So that is called as the torsion of the cyst of Morgani, or the testis where the epididymis is separating, which is a very rare cause. Differential diagnosis is epidermis orchitis. Epidermis orchitis, the most common cause for less than 40 years is chlamydia. For more than 40 years, it is E. coli because of secondary to UTI. Differentiating signs between these two conditions is given by the mnemonic pad. So the first sign is called as the French sign. So in the French sign, it is done by lifting the testes up. So upon lifting, the pain increases. Then that's a case of testicular torsion. If the pain subsides, that is a positive sign. It is a case of epididymo orchitis. So French sign is positive in epididymo orchitis. Then the next is the angel sign. So in the angel sign, and the testes they lie transversely, and then the last is the Deming sign. In the Deming sign, the affected testis it lies higher. Then you should untwisting of the testis should happen within 6 hours. Very important, 70 to 20 degree torsion. It has more worse effects than a less than 360-degree torsion. Management is by surgical exploration. After surgical exploration, if it is found to be viable, then derotation and orchidopexy is done. If it's a case of necrotic testis, and orchidectomy is done. Prophylactically, contralateral orchidopexy is also done. Now, the next condition is called as the hydrosis. Hydrosis is defined as the collection of fluid into the layers of tunica vaginalis. The color of fluid is amber colored. The specific gravity is 1.022 to 1.024. The constituents of this includes the water, albumin, cholesterol, then the bile salts, etc. The cup impulse test is coming to be negative. Reducibility does not reduce. Then we cannot get above the swelling because the tunica vaginalis it is present up to the root of penis, and the fluctuation is positive. The cross fluctuation is something that is seen in bilobuled uh, hydrocele, or that is also called as the hydrocele in Bissac. Then there are two types of hydrocele: primary vaginal and secondary vaginal hydrocele. Primary vaginal hydrocele, where the tense swelling is seen around the testes, while in secondary vaginal hydrocele, the character is that it is laxed and relaxed. Then the feel. In primary vaginal hydrocele, it can be felt, testes can be felt separately. Secondary, it cannot be felt separately. Pain is associated with secondary hydrocele. Secondary vaginal hydrocele is secondary to epididymal orchitis, which is the most common cause. Apart from that, it is associated with testicular tumors, trauma, TB, syphilis. Trans-elimination is positive in primary vaginal, it is negative in secondary vaginal because of turbid fluid. Other positive trans-eliminations include the cystic hygroma, ranula, meningocele, encephalocele, and epididymal cyst. Then false negative, it is seen in case of wrong technique. Then if there is a thick skin or the scrotum, then pyocele or hematocele. Skin color does not matter in trans-elimination. Pyocele, in the pyocele, what do we expect? In pyocele, there is a high-grade fever, there is a rapid increase in size. Hematocele generally, there is a risk of, there is a history of trauma that is given. The congenital hydrocele. The pathology of behind congenital hydrocele is the persistence of the patent processes vaginalis, and a narrow neck is present. The phenomenon is called as the inverted ink bottle phenomenon. In inverted ink bottle phenomenon, upon lying down in supine position, this swelling is going to reduce. Surgery should be done within 2 years, and the surgery that is done is herniatomy. And then the hydrocele of the cord, there is a cystic swelling of the cord that is seen. Management is excision. Then hernia of the hydrocele, that is within the hydrocele. If a particular part of hydrocele it herniates out, then that is called as hernia of hydrocele. Hydrocele of hernia, that is in the hernia. If within the hernial sac, if there is a accumulation of fluid, then that is a hydrocele of hernia. Then syphilis, that is associated with cyclical high-grade fever. Filariasis, there is a ram's horn penis that is seen. Straw colored fluid from the scrotum. Peripheral smear is done for the investigation, and the management is diethylcarbamazine for 12 days. Management of hydrocele: for small hydrocele, we do Lord's plication. For medium sized hydrocele, there is Japanese procedure, and for large sized hydrocele, there is going to be Winkelmann's procedure. Then Sharma and Sauer's method are also used. Complications in the sac, it can lead to pyocele and hematocele. In the skin, it can lead to ulceration, also excoriation. Also, there are two types: anterior ulcer and posterior. Anterior is found in syphilis, while the posterior ulcer is found in TB. Now, the testis, uh, it can lead to tubular atrophy, leading to impotence. Other causes are impotence, infertility, and all those things. So this is all about the hydrocele. Now there are some differential diagnosis of hydrocele, that is called as the spermatocele and epididymal cyst. The difference is the spermatocele is uniloculated while the epididymal cyst is multiloculated. Bunch of grape appearance is seen. The fluid in spermatocele is found to be barley colored, while in epididymal cyst it is going to be a clear colored fluid, and because of which there is a specific appearance that is called a Chinese lantern appearance or transillumination. Sperms are present in spermatocele. Management in both of them, the management is excision only if these conditions are symptomatic in nature. The next is varicocele. Varicocele, the definition is tortuous and elongated veins that are seen, that is the pampiniform plexus. The most common cause of infertility in adults. Normally, the testis has a countercurrent mechanism which is lost in case of varicocele. Now, the causes, the varicocele is most commonly seen in the left testis because first is this left renal vein, it drains into the left testicular vein, it drains into the left renal vein. Another thing is that opposite to it, there is a left adrenal vein, and this left adrenal vein, it consists of reticular veins that can lead to vasoconstriction. So again, chances of varicocele increase. Similarly, the loaded sigmoid, this is the most common cause of varicocele and renal cell carcinoma. We can get above the swelling in case of varicocele. Cuff impulse test is positive. Investigation of choice for varicocele is the Doppler, and there are three grades of varicocele. So grade 1 is where it is not visibly palpable, but Doppler it detects varicocele. Also, um, it can be palpable if the patient performs a Valsalva. In grade 2 it is palpable as well as it is detected on the Doppler. In grade 3 it is visible through the eyes only. Management. So first line management for a varicocele is percutaneous embolization of the gonadal veins. The definite management in young patients will be Palomos procedure or Ivanisevic procedure, which is varicocelectomy. While in old patients, we just go for NSAIDs and scrotal support. And next is the Fournier's gangrene. So Fournier's gangrene, the pathology behind Fournier's gangrene is the necrotizing fasciitis involving the perineal region. Now it does not involve the testes and the urethra because they have a dual blood supply. So these are compromised. Now Fournier's gangrene along with abdominal involvement, then that is called as the Melanese gangrene. The synergistic gangrene because both aerobic as well as non-aerobic bacteria they grow in it. Risk factors for Fournier's gangrene is obviously immunocompromised individual like diabetes or following a trivial trauma. Management is going to be aggressive debridement, and only the urethra and the testis is spared because of dual blood supply. Also, the newer modality includes the hyperbaric oxygen therapy. Then scrotal tumor, what are the risk factors? The risk factors for scrotal tumors are benzopyrene and shale oil exposure. Testicular tumors, the risk factors, they are undescended testes, history of tumor in contralateral testes, or Klinefelter syndrome that leads to extraconadal germ cell tumor. Now, testicular tumors are divided into two: germ cell tumors and sex called stromal tumors. Sex called stromal tumors include the Sertoli cell tumor and the Leydig cell tumor. Sertoli cell tumor, it is feminizing tumor. It will lead to gynecomastia. While Leydig cell tumor is a masculinizing tumor, and that will lead to precocious puberty in males. While germ cell tumors, they are divided into seminomatous and non-seminomatous. Seminomatous is the most common, while in non-seminomatous tumor there is choriocarcinoma, yolk sac tumor, teratoma, and embryonal carcinoma. Now, testicular lymphoma is the most common tumor that is found in adults and the elderly population, and it's the most common bilateral testicular tumor as well. Seminomatous tumors, the alpha fetoprotein levels, they are never raised in seminomatous tumor. Then there is something called as hurricane tumor. So hurricane tumor is a tumor wherein there is an aggressive choriocarcinoma, and because of which the survival is only up to 6 months. Then the workup of this patient, in the workup, the first is going to be the ultrasound. So you have to do ultrasound of the swelling. There is a testicular swelling which is going to be, or testicular mass that is going to be painless in nature. Then the second thing that you have to do is the tumor markers. So you have to assess three tumor markers: alpha fetoprotein, beta HCG, and the LDH. And then you have to do a histopathological examination by Shivasu's manure, and the staging is done by PET-CT. The very important transscrotal biopsy or FNS is contraindicated because that will lead to staging of the tumors. Now, what do you mean by Shivasu's maneuver? So, in the Shivasu's maneuver, we do a high inguinal incision, deliver the testes, and then clamp the vessels. split the testes, and whatever that mass is there, it is removed and frozen section is given. If frozen section comes out to be positive, then we have to do a high inguinal orchidectomy because the chances of metastasis are high, and if it is negative, then you have to deposit the testes. So basically it's a frozen section biopsy that is important, and this is done in Shevas's maneuver. So whatever the staging of this tumor will come, this will come out to be pathological TNM-S staging. So the PT staging that is used. So the PT1 is where the tumor is limited to the testes and epididymis, and it is not associated with lymphatic or vascular invasion. PT2 where the tumor is limited to the testes and epididymis with vascular or lymphatic invasion, or it is limited to the tunica vaginalis. Then PT3 where the tumor invades the spermatic cord and vascular lymphatic invasion is seen. PT4 is the tumor invades the scrotum. Then N1 lymph node where the size is less than 2 cm and less than 5 lymph nodes are involved. In N2 2 to 5 cm tumor and more than 5 lymph nodes are involved, and in N3 there is more than 5 cm tumor. Then the S staging. S staging is basically based on the level of tumor markers. That is measured 7 to 10 days after orchidectomy. Management of the seminomatous tumors are. The seminomatous tumors are generally found in the second to third decade of the life, is a homogeneous in nature. Histopathological examination, we know there are lymphoplasmacytic infiltrates, then nest cell or Friedreich-like appearance, nests of cells are seen. So it is further divided to stage 1, stage 2 and stage 3. Stage 1 where it is confined to the testes. Right, in the stage 1 the management is single cycle of carboplatin along with radiotherapy. Now this radiotherapy is inverted Y-shaped or dog leg field radiotherapy is done for the paraortic lymph nodes as a prophylactic measure. In stage 2, it is not only confined to the testes, so it involves the testes along with paraortic lymph nodes. In that particular thing, we go for PEP procedure, that is bleomycin, etoposide, and the P stands for cisplatin. If there is a complete response, then follow-up is required. If there is a residual disease, then we go for RPLND, that is retroperitoneal lymph node dissection or further radiotherapy. In stage 3, if there is a distant metastasis, then we go for these two procedures, that is BEP along with RPLND, and metastasectomy is done. In non-seminomatous tumors, whatever these tumors are, yolk sac tumors, then the embryonal carcinoma, teratoma, they generally occur in the first to second decade of life. The staging, it is stage 1. For that we give BEP. Stage 2 we give BEP plus RPLND where it involves lymph nodes, and in stage 3 where metastasis is present, again BEP plus RPLND and metastasectomy. So most important prognostic factor in a testicular tumor is actually the staging of the tumor, right? Okay. Then the next, this is about testes. The next is urethra. So talking about anatomy of the urethra, the female urethra is about 3 to 4 centimeters in size. Male urethra is 18 to 21 centimeters in size. The parts of the male urethra are, there is proximal and distal. So proximally there is a prostate urethra, which is the most distensible, then followed by membranous urethra. Membranous urethra is the shortest, it is the least distensible, and it's the one that pierces the urogenital diaphragm, which forms a deep perineal pouch. Then the next is the bulbar part, which is the part that is actually bent, and then the penile urethra, which is the longest urethra. Investigation, there are two investigations, retrograde urethrogram and the maturing cystourethrogram. So over here in the picture is the retrograde urethrogram. So in the retrograde urethrogram, over here you can more often visualize the distal urethra. In maturing cystourethrogram, the dye is there in the bladder, and it is used for proximal urethral pathologies, most commonly in the vesicular urethral reflex, that is VUR. Then erectile tissue is the corpus spongiosum. Then hypospadias. Hypospadias is the most common congenital urogenital anomaly. The pathology of the hypospadias is it's the ventral opening of the urethra. It is associated with undescended testes and micropenis. Then chordae is also seen. So chordae is basically the downward bending of the penis, and because of while the penis is being erect, then it is prominent, but it leads to difficult intercourse, and that can lead to infertility. So this is chordae, basically downward bending of the penis. Now the management. So the management includes the circumcision. So the circumcision is generally avoided. Why? Because that foreskin can be used for as a graft for reconstruction. The timing for hypospadias is 6 to 12 months. Then the surgery, it goes on these four steps. First is the orthoplasty. Orthoplasty is where the cord is corrected. Then the urethroplasty is where the urethra is deposited and tubularize the urethra. Then glanuloplasty is where the glans penis is reconstructed. And fourth is the skin cover. So this is how the management of hypospadias takes place. Then surgical management, the names of surgical management: for distal hypospadias, we do the Matthew and the Mustardi technique. Then for mid hypospadias, Snodgrass or tip is done. And for proximal hypospadias, Thiersch, Duplay or Dennis Brown is done. It's a two-stage repair. Then the next is going to be ectopia vesicae. Ectopia vesicae, the pathology is the anterior abdominal wall as well as the anterior bladder wall is weak or deficit is present. So that will lead to bilateral inguinal hernia, bladder extrophy that will lead to dribbling of urine, pubic diastasis for which the management is iliac osteotomy. It is associated with in males. Along with that, undescended testes can be seen in females. Bifid clitoris is seen. Okay. And urethral trauma. The urethral trauma, it can be anterior urethral trauma, posterior. Anterior urethra, it includes what? It includes your penile urethra and the bulbar urethra. While the posterior urethra, it includes the prostatic urethra and the membranous urethra. Then the mode of injury. So the mode of injury for anterior is going to be direct impact of the straddle injury, while the posterior, it is going to be the pelvic trauma. Now the next is going to be the features. So in the features, it will lead to hematoma formation. So in anterior, it will lead to superficial perineal hematoma, or it is also called as butterfly shaped hematoma. While in case of posterior, it will lead to deep perineal hematoma, which can extend up to the upper one third of the thigh, and Vermeulen sign can be seen. Vermeulen sign, that is on digital rectal examination, you will find the testis to be, you will find the prostate to be at a high position or floating position. Then the clinical features for anterior urethral injury is there's a blood at the tip of the meatus and inability to pass the urine. While in posterior urethral injury, these features may or may not be seen, but the bladder is going to be distended. Now, what is the overall most common site of injury in urethral trauma? It is the junction of the bulbar urethra and the membranous urethra. Investigation of choice for urethral trauma is going to be the retrograde urethrogram. Then management: Foley's catheter should not be used. If we catheterize this patient, then the partial tear can give rise to complete tear. If the bladder of the patient is found to be full, that is, if the accurate retention of urine is present, in that case suprapubic catheterization is done. And if the bladder is not full and the patient does not have much complaints, so it's not does not have much discomfort, then in that case trial of maturation can be given. Next is urethral stricture. Now the stricture can be a short stricture or long stricture. In the short stricture, it can be incomplete or complete stricture. So for the management of short incomplete stricture, the management is OIU and VIU. OIU stands for optical internal ureterostomy. So optical internal ureterostomy. In short and incomplete, we go for resection and end-to-end anastomosis. So resection and anastomosis is done. For long and complete, we cannot go for resection and anastomosis. So we go for resection, but we need to place a graft. The most common graft that is used is the buccal mucosal graft, and the technique is called as the Barbagalli's technique. Barbagalli technique. Now the next is going to be about the penis. So the first pathology is the fracture shaft of the penis. In the fracture shaft of the penis, the pathology is there is a tear in the corpora cavernosa or the tunica albuginea of the penis. The deformity, it will lead to eggplant deformity. Then the management is we have to drain the hematoma, and OC pills they are given for 1 month to prevent the erection. Then posterior urethral valves is found only in males. In severe cases, it may be associated with hydronephrosis or recurrent UTI infections is seen. Then there are different classification. The classification is called as the Young's classification, and in the Young's classification, the class 1 is the most common. Then class 2 is rare, and class 3 is called as the Cobb's scholar. On the investigation of choice over here is going to be the maturing cystourethrogram. On maturing cystourethrogram, this particular sign can be seen, that is called as the keyhole sign, and the management is fulguration of wall. Then the Peyronie's disease. Peyronie's disease is associated with IgG4, so that is retroperitoneal fibrosis along with the Dupuytren's contracture. The investigation of choice is MRI. The management, for the first line management, we give a intralesional injection of collagenase, which is derived from Clostridium histolyticum bacteria. If it fails, then go for Nesbitt's procedure or 16 dot procedure. In the 16 dot technique, we use the non-absorbable sutures, and counterbalancing of this pressure is done. Then priapism is the erection of the penis. If the erection of penis for more than 4 hours. If it is for more than 6 hours, that will lead to ischemic necrosis. Now, this priapism is of two types: high flow and low flow. High flow, the pathology is that the blood flow is maintained, so that is because of increased inflow of blood, while low flow is because of venous blockade, and the low flow is going to be more common. Then the causes of high flow, they are going to be secondary to trauma, if there are pathogen injection that is taken, or if there is any spinal injury or anesthesia. Then the secondary, then the low flow. The low flow, it is causes are, it can happen in children due to scorpion bite, then sickle cell anemia or leukemia. The low flow is associated with pain. Then on blood gas analysis, in high flow, because it is arterial blood, so oxygenation will be seen. Here there is a deoxygenated blood that is seen. Investigation is the penile angiography, so that we can come to know the site of block. Management, we sedate the patient, then go for adrenaline injection. Adrenaline injection will lead to vasospasm, and that will lead to reversal of priapism. If it still persists, then we go for shunt surgery, and the shunt surgery, that is called as the Gray-Hack shunt. Gray-Hack shunt. And there is a persistent high flow priapism, then in that particular case we can go for embolization as well. Penile cancer. Penile cancer, the most common type is common cell carcinoma. The most common gene involved is the p53 gene, and the variant that is associated with human papilloma virus is called as the Bushke-Lowenstein tumor. It is similar to the Ackermann's tumor of oral cancer. Pre-malignant conditions, the Bowen's disease, which involves the shaft of the penis, while the erythroplasia of Chirat, it involves the glans of the penis, and that will together lead to an appearance that is called as a sunburn appearance, and there is a reddish colored papules that are seen on the glans. Apart from that, there is a balanitis obliterans that increases the chances of phimosis. Neonatal warts are seen because of HPV and leukoplakia. These are all the pre-malignant conditions. Investigation of choice is going to be the biopsy, where the keratin pearls can be seen. Staging, it can be done with the help of TNM staging, or there is another staging that is called as the Jackson staging. For local spread, we use the MRI, and for distant metastasis, it is going to be the PET-CT. Management of the Bowen's disease is a 5-fluorouracil cream, and if it's a penile cancer which is more than 2 cm away from the root of penis and the margin is more than 0.5 cm, in that particular case partial penectomy is done, while a total penectomy, that is complete amputation, is done when it is less than 2 centimeters from the root and having a margin of more than 0.5 centimeter. When we do a total amputation of the penis, then we have to also do a ureterostomy. So perineal ureterostomy is done. So it is a stoma is created in the perineum for the urine to flow. The most important prognostic factor in carcinoma of penis, it is going to be the lymph node status, and the most common cause of death is going to be these lymph nodes that are getting involved, and when these lymph nodes are getting involved, then that can lead to erosion of the femoral or the iliac vessels. So this is going to be very important. So the most important prognostic factor in carcinoma of the testes was the staging, while here it is going to be the lymph node status. Now the sentinel lymph node biopsy was done by Cabana in carcinoma of penis. Phimosis. Physiological phimosis is seen up to 2 to 6 years of age. If it is more than 6 years of age, then that is pathological phimosis that can lead to recurrent urinary tract infection or balanophthitis. Ballooning of foreskin is seen because of the retention of urine. The management in this particular condition is going to be the circumcision. Then complications post-op, there can be bleeding. The most common vessel that bleeds is going to be the frenular vessel, infection and cord deformation. The next is paraphimosis. Paraphimosis causes a constriction ring that is formed at the foreskin around the penis, and because of which the whole penis head is painful and swollen. Management, conservative management by using a lignocaine or silocaine jelly. Multiple punctures are made so that this constriction ring gets away, but if still fails, then we go for a surgery that is called as a dorsal slit surgery. So this is about the urethra and the pelvis as well. So starting off with the first thing, that is the kidney now. So the kidney, the development and the site of the kidney. So development of the kidney, it happened through the metaleptic birds. The site of the kidney is the iliac fossa. Preferred donor kidney is the left kidney because the left renal vein is more than the right renal vein, while the left renal artery is smaller than the right renal artery because abdominal outwards towards the left. Then the next is the testis which is prone for varicocele is the left testis, and the secondary varicocele also happens in the left testis because the left renal vein drains into the left testicular vein drains into the left renal vein. Similarly, the RCC, renal cell carcinoma, spreads to the veins. Now, nutcracker syndrome. Nutcracker syndrome is basically the left renal vein. It gets compressed between the aorta and the and between the superior mesenteric artery. So that will lead to the nutcracker syndrome. Then the renal collar is again formed by the left renal vein, where the left renal vein, it splits to encase the abdominal aorta. Arrangement of the hilum of the kidney from anterior to posterior is vein, then artery, and then the pelvis. Now, very important is this transplant criteria. So transplant criteria has been discussed in the transplant module, but over here also I will discuss that in the veins. So in the veins, we should know that VE. So whether it's a live donor or a deceased donor, in that in both of these cases, there is an end to side anastomosis, and anastomosis of the donor renal vein, it is done with the recipient's external iliac vein, while arterial anastomosis in the deceased, it follows the same criteria as that of the veins. So in deceased person, it is the end to side anastomosis, and also it is there with the external iliac artery. While in case of live donor, it's completely opposite, that is end to end anastomosis is done with internal iliac artery. Now, that is the renal agenesis. So renal agenesis is more unilateral as compared to bilateral. It is also associated with agenesis of the ureter as well as the hemitrigone. Now it is also associated in males with undescended testes, while in females it is associated with the absent fallopian tube. Now talking about the duplication. So duplication of the ureter, it follows the Wiegert-Mayer rule. So Wiegert-Mayer rule states that there is one ureter that drains from the superior lobe or the upper lobe, while other ureter it drains from the middle as well as from the lower lobe. The ureter that drains from the middle or the lower lobe is generally implanting at a normal location, while the one that is draining the upper lobe, it drains into the ectopic location, which is posterolateral to the normal location. The investigation of choice is the intravenous urogram, and it shows a dye, that is urographin dye. Then the clinical features in males, they are generally normal because it drains into the urethra of the males, but in females it drains into the vagina, and because of which the mother will come that a child is never dry since birth. On intravenous urography, there is a drooping lily sign. So this is the drooping lily sign that is seen on intravenous urography. Similarly, the duplication of the ureters can also be seen. Now, the next is going to be, and the management. Management is obviously going to be the reimplantation of the ectopic ureter. Next is the polycystic kidney disease. The polycystic kidney disease, the most common presentation is the hypertension in the young patient. It is associated with hematuria. Most common extrarenal manifestation is going to be hepatic cyst, and ABCD as a features. So in ABCD, there is aortic dissection, mitral valve prolapse, various aneurysm, or colonic diverticulosis. Management over in this patient is drugs, V2 receptor blocker, that is conivaptan, rotelvaptan, mTOR inhibitors can be given, dialysis, and definite management is the transplantation of the kidney. Rousing procedure was done earlier, rousing procedure. This can also be diagnosed on a prenatal scan. Prenatal scan criteria is that in a single kidney, if more than or equal to 3 cysts are seen, or in both the kidneys, if more than 2 cysts are seen. It is divided into two: infantile PKD and adult PKD. Adult PKD is autosomal dominant in this inheritance, while infantile is autosomal recessive. It is located with chromosome 6, while autosomal dominance is associated with chromosome 4 and 16. Then, so this is going to be the image of a polycystic kidney disease. So here we can see the multiple cysts in the kidney, and this is a CT image showing multiple cysts in the kidney. Then the next is multicystic dysplastic kidney. This is one of the congenital conditions where abdominal lump is present at birth and it is not compatible with life. Then there is a horseshoe-shaped kidney. In horseshoe-shaped kidney, the lower poles of the kidney are fused, and they are this kidney, it originates from the iliac fossa and then it ascends upward into the lumbar region. It is stopped at the level of L3, L4 with the help of inferior mesenteric artery. However, the adrenal glands, they are normal. On intravenous urography, you will find a flower vase sign or a handshake sign. So over here you can see this is a flower vase sign, or this is going to be a handshake sign that is seen. Similarly, on CCT you can see this lower poles of the kidney to be fused. Then the next is going to be hydronephrosis. It is the aseptic dilatation of the pelvic calyces or the renal calyces. So normally the renal calyces are cup shaped, but then there is a clubbing of those calyces that is seen in hydronephrosis. Now hydronephrosis, it can be caused because of unilateral causes, or there can be bilateral causes. The unilateral causes are further divided into intraluminal, intramural and extraluminal causes. So first is the intraluminal causes. The most common intraluminal, most common acquired cause is going to be the stones, so renal calculi, leading to hydronephrosis. Other intraluminal causes are where the slowed papillae, they are seen. So slowed papillae are seen in diabetic mellitus or in analgesic abuse. Then the next is the intramural causes. The intramural causes, and the most common congenital cause is the PUJ obstruction, that is pelvic junction obstruction. In pelvic junction obstruction is adynamic obstruction, and the investigation of choice is the MAC3 scan. MAC3 scan is a functional scan actually, and the management of this is going to be Anderson-Hines pyeloplasty. So in the so this over here you can show the clubbing of the sinuses over here, that is hydronephrosis. Then another intramural cause is the transitional cell carcinoma, which shows a goblet sign. So over here this sign is called as a goblet sign, which is seen in transitional cell carcinoma. Then next is going to be the ureterocele. So ureterocele is one of the cause for recurrent UTI. Intravenous urogram, you will find a dilatation of the ureters at the end. So cobra head sign or adder head sign is seen. Management is endoscopy and excision of this. So over here you can see the dilatation of the ureters at the terminal end. It shows a cobra head or a adder head sign. Next is retroperitoneal fibrosis. Now this is going to be extraluminal cause. So retroperitoneal fibrosis, it is also called as the hormones disease. It's caused because of drugs like methotrexate or bromocriptine. It's IgG4 related disease. On intravenous urography, you will find this sign that is called as a maiden waist sign. Because of fibrosis, the ureters, they are brought close to each other, so that shows a maiden waist sign. And the management of this is to put a degestant, so that to maintain the patency of these ureters. Next, retrocaval ureter. So as the name suggests, it is retrocaval, that is behind the vena cava, and inferior vena cava is on the right side. So it's the right ureter which is lying behind the inferior vena cava. The intravenous urography of this, it shows a fish hook sign or the reverse J sign. So this is the reverse J sign, or this is going to be the fish hook sign. Next, the bilateral causes. The bilateral causes, they are going to be bladder outlet obstruction, benign prostatic hyperplasia, posterior urethral wall. The posterior urethral wall, in the vegetative cystogram, it shows the keyhole sign. It is only found in males, and the management is perforation of these walls. Then renal isotope scan. The renal isotope scan most commonly does is the technetium 99 DMSS scan. It tells us about the structural aspects of the scarring inside the kidney, but DTBA scan or the MAC3 isotope scan is better because it shows the functioning of the kidney as well. Management of hydronephrosis most commonly deals with the managing the causes of hydronephrosis, and if the GFR of the kidney is found to be less than 10%, then in that particular case you have to go for nephrectomy. Then the next topic is very important, that is the renal stones. So the first thing is the most common stone inhibiting factor is going to be the citrate, right? And then the most common stone that is formed is the calcium oxalate. It is found in acidic urine, and it is resistant to ESWL. There are two types, mainly three types: calcium oxalate monohydrate stones, which are dumbbell shaped; dihydrate stones, which are envelope shaped; and then there is a speculated stone, that is mulberry stone, which is going to be painful in nature and it will lead to hematuria. Management, you have to decrease the fats in the diet and increase the calcium, and cholestyramine should be taken. Then triple phosphate stones or stovite stones are the staghorn calculi. So these are the stones. These are characteristic that they take shape of the calyces. They are found in alkaline urine. These are the biggest ones. Proteus is the organism that is found over here, and is caused because of laxative abuse. The appearance is going to be a coffin lid appearance. And cystine stones, that are hexagonal in nature, is the most resistant to extracorporeal shockwave therapy, and the management is going to be depenicillamine. Uric acid stones, these are translucent, most common translucent stones. They have a shape like glass shards. They are seen in tumor lysis syndrome and gout. Another radiolucent stones are Indian triantenal and xanthine. Now, how to clinically diagnose the renal stones? So, there are going to be specific clinical features with which the patient comes. If it is a pelvical stone, then joint to groin pain is seen. In upper and mid ureter, it is along the ilioapicogastric nerve or the obturator nerve, and along the lower ureter, it is ilioinguinal nerve. So, as we go from up to down, then the pain goes lateralized. Okay, then the intramural stones that is in the bladder, it will lead to strangury. So what is strangury? It is basically a very big urge to urinate, but because of the pain at the tip of the meatus, the patient cannot urinate fully. Only some drops of urine is evacuated. Investigation of choice for any stone is going to be NCCT. And diabetes crisis is that sometimes the stones, they are going to block the or going to obstruct the flow, and because of which the kidney becomes palpable and distended. Now, upon change of the position, sometimes these stones can be displaced, and a large volume of this urine then flushes out. So that is called as the diabetes crisis. So here in the image you can see this is going to be the stagon calculus or the strobite crystals which take the shape of the calyces, and this is the uric acid crystal which is radiolucent. Here this is the NCCT showing the renal stone, this is the X-ray KUB showing a big bladder stone, and then this is going to be stones in the ureter. And management of the stones, if it is less than or equal to 5 millimeter, you have to do a conservative management. If it is more than 5 millimeter, first line medical therapy is given, that is alpha 2 agonist, that is tamsulosin. This is going to relax the muscles. Then the next is the extracorporeal shock wave lithotripsy, ESWL. ESWL, it will is contraindicated in many cases, that is in pregnancy, when there is a pacemakers, in children it is contraindicated, or if the stone size is more than 1.5 centimeter, then cystine stones and calcium oxalate stones are resistant to it. It cannot be used in lower pole stones and obstructed system. Also in ESWL, if the stones, they are broken down and they come along the ureter, then it shows a stone street appearance, so the screen strasse appearance. Then next is RIRS, that is retrograde intrarenal surgery. This can be done for stones less than 2 centimeters, and it can be used for lower pole stones. Then next is PCNL, that is percutaneous nephrolithotomy, for stones more than 2 centimeter, lower Gallic stones, stagon calculus, or hydronephrosis. The most common complication associated with PCNL is hydronephrosis, is bruising. Sorry. The next is ureteric stone. Ureteric stone is removed by ureteroscopic removal, URS, using the Dormia basket. The laser used is Holmium YAG laser. Differential diagnosis is with the gallbladder stone, but we can differentiate it by using lateral X-ray. In the lateral X-ray, the gallbladder stone appears to be anterior. The bladder stone, can be divided into two types: primary and secondary. Primary, it is common in children, secondary is common in adults. In the primary, the most common is going to be the mixed urate stones, while in adults it is calcium oxalate or the Jack stones. Management is per urethral cystolithotomy, and suprapubic cystolithotomy is done when there is a urethral stricture or there is a diverticulum in the bladder. Now the next is going to be the vesicoureteric reflux. So next is going to be the vesicoureteric reflux. Over here, the investigation of choice is the maturating cystourethrogram. Right, on this maturating cystourethrogram, you can see this different 5 grades. So in the grade 1, there is a reflux of urine into the mid ureter without no dilatation. In the second, it goes up to the calcial system, but still there is no dilatation. In the grade 3, it goes to the pelvicalcial system with dilatation. And in grade 4, tortuosity happens and a blending of calyces. In grade 5, it becomes very much dilated and largely tortuous with papillary impressions, and it's a case of established hydronephrosis. Management for grade 1 to 3, antibiotic prophylaxis should be given. For 4 to 5, you have to do the intervention. So endoscopically, either sting procedure can be done or the HIT procedure can be done. So sting procedure is subureteric Teflon injection, or the HIT is hydrodentation implantation technique, and in open procedures there is a polyethylene Leadbetter technique. The next is the trauma. So in the trauma module, we already talked about there are 3 zones of the trauma. The zone 1 is having maximum mortality because the major blood vessels are located, that is the IVC, then the abdominal aorta and the pancreatic head. Then zone 2 is where the kidney, ureter and the renal vessels are included, and zone 3 is having the pelvis region, which is most commonly traumatized zone. Now talking about the zone 2 injury, that is renal injury, if the patient is stable, then CCT is done. If the patient is unstable, then in single shot intravenous urogram is done. If in cases the renal artery stenosis has taken place, in that case, when you inject a dye, then non-visualizing of the kidney will happen. Then that means a retroperitoneal dye accumulation might happen. Now there are grades of renal injury, and pneumonic is look. So grade 1 is subcapsular hematoma, grade 2 is laceration less than 1 centimeter, grade 3 laceration more than 1 centimeter, then grade 4 is urinoma. If it's a sterile urinoma, we go for digestant. If it's a septic urinoma, we go for pigtail catheter. And fifth is the shattered kidney, wherein there is either a partial nephrectomy or total nephrectomy needs to be done. Then the complications will be the hematuria and all those complications. Meteorism is a very important complication. It is due to pressure on the splanchnic nerve. There is a colonic distension that happens. Then the next is ureteric injury. The ureteric injury more commonly happens in the OBGYN surgeries like hysterectomy and all, salpingotomy, wherein the points of ureteric injury will be uterine vessel ligations, so gonadal vessel ligations, or the dissection of bladder. So ligation of uterine or gonadal vessels and bladder dissection. Investigation: CT urography or intravenous urography. The management: if ureteric injury has happened, if it is realized during the surgery by the surgeon, by the obstetrician, then either it can be a partial damage or complete damage. So if the partial damage is present, absorbable sutures can be placed. If it's a complete damage, then we have to see if the loss of segment is present or not. If there is no loss of segment, then simply anastomosis or the digestion can work. If there is loss of segment, then in that particular case, bore flap repair or psoas hitch can be done. Then after surgery, if it is seen that there is thing, then the complications can be urinoma formation, so digestant or either a pigtail catheter can be used depending upon whether it is infected or not. Then fistula formation is one of the most complex complications, and there is a ureterovaginal fistula that is found. Now the next is going to be the renal tuberculosis. So the mnemonic is PG से पहले KG में था. So P stands for papillary ulcer, which is the earliest sign. Then ghost calluses, that is moth eaten callus. Then the next is perinephric abscess, that is drained by pigtail catheter. Then putty kidney, seventh kidney. Then Kurz king. Kurz king actually is the kink at the uretropelvic junction, and management is the digestant. Then the gall hole orifice, that is ureteric orifice, management is reimplantation of the ureter. Then thimble bladder. Thimble bladder, the management is augmentation cystoplasty. Then there is a boggy prostate and a beaded vas. Investigation of choice for renal TB is the CT urography or sterile pyuria, wherein the pulse cells are present. Gold standard is TB culture. Then the pyelonephritis. Pyelonephritis has got two types, that is emphysematous and xanthogranulomatous. But overall, remember, pyelonephritis, the most common causative organism is the E. coli. It is secondary to urinary tract infection. It is more common in females. First, we start with IV antibiotics and then complete with the oral antibiotics. WBC casts are seen. Investigation choice is the CECT. Then, as I said, two types, emphysematous and xanthogranulomatous. In emphysematous type, the most common cause is E. coli. It is found in immunocompromised individuals or diabetic individuals. And over here, the gas can be seen around the kidney. So there's a collection of gas around the kidney, and that is called as a Murphy's punch sign. This Murphy's punch sign means a pain is present at the costovertebral angle. Then the next is xanthogranulomatous. In the xanthogranulomatous pyelonephritis, we can see that there is a bare paw sign that is seen because of increased number of the calluses and the multiloculated appearance in a enlarged pelvis. So this is the xanthogranulomatous type. The most common causative organ is the protease because it happens in alkaline urine. So staph calculus is also seen. Generally seen in middle-aged female diabetic, and management is going to subcapsular nephrectomy. Now moving on to the next very important topic, that is the renal tumors. The renal tumors. So these renal tumors are mostly found by the radiologists. The classification that is used is the Bosnian classification. Bosnian classification class 1, it's a simple cyst with 0% chances of malignancy. In 2, it's a complex cyst, minimally complex in nature, again 0% chances. 2F, that is follow-up, is required with 5% chances of malignancy. In 3, it's an indeterminate cyst and 50% chances of malignancy. And in class 4, it's a clear malignancy having 100% chance. This is the putty kidney, this is bovary flap repair. Then, talking about the benign tumors, the first is going to be angiomyolipoma. Angiomyolipoma is a picoma, that is perivascular epithelioid cell tumor. It is found in the 5th to 6th degree. It is associated with tuberous sclerosis. Then there is a Wunderlich syndrome that is associated with it. So the Wunderlich syndrome is there is a pain, then there is a hypotension that is because of the retroperitoneal hemorrhage. So there is a concealed hemorrhage that happens in the retroperitoneal region, and a mask is present. This particular triad is named as a Link's triad. Right, and there is no hematuria during this. Then the bleeding if it is present, then in that particular case we have to go for angioembolization and then followed by definite management. If it is less than 4 centimeter, then conservative; more than 4 centimeter, then partial nephrectomy is done. Angiomyolipoma is a Boston grade 3 tumor. It's indeterminate in nature. Over here on the CCD you can see this low density fats because it's a lipoma as well. And oncocytoma as the name suggests, there are a high number of mitochondria. Most common benign tumor associated with chromosome 17 Birt-Hogg syndrome and is similar to chromophobe RCC. There's a central stellate scar that is seen on CCT, and also it has got a eosinophilic cytoplasm because of increased number of mitochondria. Now talking about the carcinoma, renal cell carcinoma, it is also called as hypernephroma or internus tumor. The risk factor are thoroughtrust exposure, tobacco, or increased protein intake. There are different types of it. Clear cell carcinoma. The structure where it is seen is the proximal convoluted tubule associated with von Hippel-Lindau syndrome, that is deletion 3p, and it is associated with cerebellar hemangioblastoma. Then papillary cell carcinoma, it is associated with cement gene PCD and associated with long-term dialysis. Chromophobe RCC, the immunohistochemistry is cytokeratin positivity and best prognosis. Papillary RCC shows the Samoma bodies, while clear cell carcinoma shows clear cells on histopathological examination. Most common clinical presentation is the hematuria. Most common site of metastasis is lung. Most common paraneoplastic syndrome is going to be raised ESR, while other paraneoplastic syndromes can be hypercalcemia, polycythemia, Cushing syndrome, Lambert-Eaton syndrome, and non-metastatic hepatic dysfunction is seen, and this is called as the Stoffer syndrome. Stoffer syndrome is because of interleukin 6. Then the most important prognostic factor is going to be the pathological staging of this tumor. So the name of it is given a specific name that is called as the Robson staging. And the grading is called as the Foreman's grading. TNM staging of this tumor is very important. In the TNM staging there is T1, T2, T3, T4, and the T1A, it is less than 4 cm in size, confined to the kidney. T1B 4 to 7 cm, confined to the kidney. T2 is more than 7 cm, confined to the kidney. Then T3 is where it goes outside. T3A where it invades the renal vein. Then T3B into the supradiaphragmatic part of the IVC, and T3C is going to be T3B is infradiaphragmatic part of IVC, and T3C supradiaphragmatic part of IVC. T4 is ipsilateral adrenal gland, that is, it goes beyond the gyrodas fascia. Then N1 means the paraortic lymph nodes are involved, and M1 means metastasis. Most common site of metastasis is lungs. Management, it is chemoradiotherapy resistant, very important. The renal cell carcinoma is resistant to chemotherapy as well as radiotherapy, while the Wilms tumor is chemo and radiosensitive tumor. So my management is either nephrectomy, so partial nephrectomy or radical nephrectomy. Partial nephrectomy is done in all the benign conditions. Apart from that, it is done in T1 tumors, that is about up to 7 cm, confined to kidney. It is done in bilateral renal cell carcinoma, and if there is only a solitary kidney or there is a decreased function of the other kidney. Then radical nephrectomy is the nephrectomy that involves removing the kidney, the gyrodas fascia, along with the sentinel lymph node, that is the paraortic lymph nodes, and a ureter till the brim. Cryoablation is done in T1A, that is less than 4 cm tumors that are confined to the kidney, and in elderly population. Then the next is the Wilms tumor. Wilms tumor is the most common pediatric tumor. It is the second most common cause of abdominal malignancy in children. The most common cause of abdominal malignancy is going to be neuroblastoma. So in the neuroblastoma and Wilms tumor, the difference is that this neuroblastoma, it crosses the midline, while the Wilms tumor does not cross the midline. The neuroblastoma is associated with intratumoral calcification, while in Wilms tumor there is peripheral calcification, that is seen on CECT. Neuroblastoma, the urine VMA levels increased. Over here in Wilms tumor, they are normal. Then the Wilms tumor also spread along the renal veins and it goes to the lungs, similar to RCC. Then it is associated with chromosome 11p. So 11p13 and 11p15. 11p13, it is associated with Denny-Stash syndrome or the Wagner syndrome. Then 11p15, it is associated with Beckwith-Wiedemann syndrome, where there is macroglossia and ipsilateral on one side there is going to be hyperplasia. It is chemo and radiosensitive in nature, so it has got a good prognosis. Now there are multiple components to this Wilms tumor, epithelial component as well as blastomal component. More the amount of blastomal component, poorer is the prognosis. So the most important prognostic factor over here is the blastomal component, while the most important prognostic factor in renal cell carcinoma is going to be pathological staging. So right now we have studied about testicular tumor. So testicular tumor, the most important prognostic factor was the staging. Then penile cancer. In the penile cancer, the most important prognostic factor was the lymph node status. In case of RCC, it was again the staging, and now again in case of the Wilms tumor, it is going to be the blastomal components inside the HPE. So these are the important prognostic factors. Now the staging, stage 5 is nothing but bilateral Wilms tumor. Bellini cancer, it is a collecting duct cancer. It has got a worse prognosis associated deletions with Q. Medullary renal cell carcinoma, it is associated with sickle cell anemia. So the next is going to be the bladder. In the bladder, we have the three-way Foley's catheter. The three-way Foley's catheter is used when it is used when there are clots in bladder. So irrigation is done through one way. What is the difference between the rubber and silicone Foley's? Rubber Foley's can be used for up to 30 days, while the silicone Foley's can be used for 3 months, that is 90 days. Then stuck Foley's, if the Foley's is stuck, that is if we are not able to retract it, then in that particular case the practical way is to cut the balloon port, but the ideal way is to do a ultrasound guided balloon puncture. Then difficult catheterization in males. If there is a difficult catheterization in male, then Cowday's tip catheter, Cowday tip catheter is used. It is rigid and it has got angulation. Now most commonly it is 18 gauge. Acute urinary retention. In acute urinary retention, the kidney function test is normal. It is associated with pain. Management is suprapubic catheterization if the bladder is full, or Foley's catheterization. Then chronic urinary retention. Chronic urinary retention, again the management remains the same: Foley's catheterization, suprapubic catheterization. Here it is not associated with pain, or the pain is less. Kidney function test is abnormal. Uremia can be present or absent. Now what happens is, if we do Foley's catheterization, there is sudden post-operative obstructive diuresis can happen, and this can be prevented by aggressive IV fluids. There is sudden decompression, it can lead to hematuria, and it can be prevented by using the clamps in the Foley's catheter. Now there is something called bladder trauma. Bladder trauma, it is divided into two: extraperitoneal and intraperitoneal. Extraperitoneal, out of which is more common as compared to intraperitoneal. Extraperitoneal bladder trauma, it is secondary to the straddle injury. It is secondary to pelvic fracture or the proximal urethral injury, while the intraperitoneal, it is secondary to the bladder outlet obstruction, benign prostatic hyperplasia, or the bladder neck stenosis. The extraperitoneal one, it is associated with the intraperitoneal bladder trauma. It is associated when the bladder is full and there is a direct impact on the bladder, for example in cricket matches, or there is a surgery like hysterectomy. Then it is the extraperitoneal is associated with blood at the tip of meatus, deep perineal hematoma, and there is a difficulty in passing the urine. While the intraperitoneal one is associated with peritonitis and syncope. The investigation of choice for extraperitoneal is going to be CT urography, and the management is going to be Foley's catheter or suprapubic catheterization for 7 to 10 days, while in intraperitoneal one, the management is going to be exploratory laparotomy is needed. Now the grading of this bladder trauma is not very important. Grade 1 is hematoma or laceration of partial thickness. Grade 2 is extraperitoneal laceration less than 1 centimeter, less than 2 centimeter. Grade 3 is extraperitoneal laceration more than 2 centimeter, or intraperitoneal laceration of less than 2 centimeter. Grade 4 is intraperitoneal laceration of more than 2 centimeter, and grade 5 is laceration that is extending up to the bladder neck or trigon. Now this is the CCT image of the extraperitoneal rupture, wherein here you can see this urine is getting activated. Similarly, this is the X-ray image of bladder getting disrupted. The next is bladder diverticulum. Bladder diverticulum is nothing but the outpouching of the bladder. It can be either primary or congenital in nature, or secondary. The primary or congenital bladder diverticulum, it is associated with the herniation of the mucosa, and it is also called as the Hutch diverticulum, while the secondary diverticulum is called as pulsion diverticulum. It is because of pressure, and now this is because of actually benign prostatic hyperplasia, bowel outlet obstruction, then bladder neck stenosis, right? There is repeated urge to pass the urine on change of posture, and CT urography is the investigation of stress. Over here we can see this diverticulum management. It is symptomatic, and large cases only we go for diverticulectomy. Then moving on to the next, that is the bladder cancer. So in the bladder cancer, there are three types: transitional cell carcinoma, which is the most common, then squamous cell carcinoma, and the adenocarcinoma. Squamous cell carcinoma, it is associated with three C's. The three C's of squamous cell carcinoma are cyclophosphamide, then it can be the cigarette, and the third C is going to be the chemicals, that is the aniline dye or rubber industry. In squamous cell carcinoma, it is associated with smoking. It is most commonly seen in African Americans, and also schistosomiasis, that is bilharziasis. Adenocarcinoma, the most common site is the trigone of the bladder, and it is associated with the persistent urachus. Most common presentation is a gross painless hematuria, then metastasis to the obturator lymph nodes, and a distant metastasis is found to the bones. So very important, in the renal cell carcinoma, the parietic lymph nodes are involved and a distant metastasis to the lungs. Over here, the lymph node involved is the obturator lymph node and a distant metastasis to the bones. Investigation of choice is the cystoscopic biopsy, and the cystoscopic biopsy, it involves the cold cup biopsy of the base. Now this biopsy is taken post turbidity, that is post transurethral resection of the bladder tumor, and then it is sent for staging. It is done by India laser. So pathological DNA staging: T0 is no tumor, TA, it is a non-invasive papillary cancer, then TIS, that is in situ, and T1, that it involves the lamina propria. So these are the together called as non-muscle invasive, because from T2 it involves the muscularis layer, and in T3 it involves the perivesical tissue, and T4 it involves the adjacent structures. So what is the management? The management for each TA, TIS and T1 is different. For TA, it is TAM into 1. What is TAM into 1? It consists of intravesical chemotherapy using thiopita, adriamycin and mitomycin C and 1 cycle. Then for TIS, that is in situ, and T1, it is intravesical BCG 6 cycles. And then for T2, T3, T4, there is a neoadjuvant chemotherapy followed by surgeries needed. Now check cystoscopies that should be done for every 3 months. The urinary marker for recurrence is the NMP22. Then surgery, there are two types of surgery: partial cystectomy and radical cystectomy. The indications for partial cystectomy over here, they are the small tumors, carcinoma on the dome of bladder, and carcinoma away from the ureteric orifice. Then the radical cystectomy, it involves the structures like the bladder, the prostate in males, urethra in females, and iliac or the obturator lymph nodes. Now after the whole thing is done, that is basically the bladder is removed and the urethra is also removed, the thing that is important is the urinary diversion. So urinary diversion is done in post-cystectomy, it is done in ectopic vesica as well as in neurogenic bladder. Now it is of two types: continent and non-continent. Continent means where the voluntary control of the patient remains, and this is nowadays preferred by by constructing a new bladder using the ileum. Otherwise, earlier the non-continent routes where the most common it was used was ureterosigmoid anastomosis. Sounds cool because the urine will go through the sigmoid colon, and through the rectal orifice it will come out. But however, it has got a maximum complications because there are high risk of urinary tract infection. Adenocarcinoma risk, it increases by about 100 times in this, and also it leads to hyperchloremic, hypokalemic metabolic acidosis. Hyperchloremic, hypokalemic metabolic acidosis. Another was ileal conduit by creating a stoma. Again, it led to the same complication, that is hyperchloremic, hypokalemic metabolic acidosis, that is more chlorine, less sodium. Now apart from that, other complications were stenosis, strictures and all this. So nowadays the best is continent by using a new bladder, creating a new bladder. Most important prognostic factor for bladder cancer is the depth of invasion, that or the T1 stage, right? The T stage, basically the T stage talked about the depth of cancer. So T1, it is lamina propria, T2 it invades the muscularis, T3 into the perivesical structures, and T4 into the adjacent structures. So the depth of invasion is important. So if we now compare all the important prognostic factors for different cancer. So now if you compare all these factors, so for the testicular tumor, it was the staging of the tumor that was important, and for the penile cancer, it was the lymph node status that was the most important prognostic factor. For renal cell carcinoma, again it is going to be the staging. For Wilms tumor, on the histopathological examination, the blastomal the blastomal component, more the blastomal component, poorer was the prognosis. And for bladder cancer, again it is going to be the depth of invasion or the T stage, right? So these are the different prognostic factors. Now the next is the urethral abnormalities. So in the urethral abnormalities over here, first the thing that you can see is it is normal. Over here you can see this is the patent urethra. Over here you can see the urethral cyst where non-obliteration has happened over here. Here the non-obliteration has happened at the umbilical region, that is called as urethral sinus, and urethral diverticulum where the bladder diverticulum it is not obliterated. And the problem with this is that whenever the patient or whenever the child does any stressful activity, the urine it comes out to the umbilicus. So that's the problem. This persistent uricus in all these three cases, the complications is that it leads to adenocarcinoma risk, and management is going to be excision. Now there are certain conditions like bladder extrophy, it is also called as ectopia vesicae. It is associated with other conditions. For example, there is a dribbling of the urine, anterior abdominal wall and anterior bladder wall defects. So it is associated with hypospadias, then undescended testes, and associated with indirect inguinal hernia. Management for this condition, that is bladder extrophy, is so the management is going to be the is the primary closure. Primary closure is to be done within 48 hours to 72 hours, that is within 2 to 3 days. And apart from that, epispadias repair should be done. So very important, is not associated with hypospadias, it is associated with epispadias. So epispadias, pubic diastasis is present, right? For that ileocolostomy is ileosteotomy is done. So pubic diastasis, then undescended testes and indirect inguinal hernia. The TB bladder, the early sign is pallor around the orifice, and late sign is going to be gulf wall orifices or thimble bladder. In interstitial cystitis, it leads to here the punctate hemorrhages and fissures are seen, and the characteristic ulcer that is associated with it is called as the Hunnan ulcer. Then cystitis cystica, where chronic cystitis is seen and a lot of cysts are seen. Then Marion's disease, I stands for hypertrophy of the internal urethral sphincter, and because of which it leads to lower urinary tract symptoms. Now the next is going to be prostate.